Well, thank you very much for coming here to this community conference. This has been the brainchild of Martin Straker-Welds, who was just having his photograph taken with us a few minutes ago. He's the Labour councillor for Moseley and King's Heath, and he organised a previous conference 3 years ago on the same theme, so it's a chance to see what's happened since. So many thanks to the Labour Party members who've been helping to organise this, and to the Unite the Union, who were part of the organising committee and who provided a lot of organisational and practical support, including those packs on your seat, which we'll come to. First of all, important thing, domestics. If there is a fire, you will hear a fire alarm. There's no fire alarm test planned. It would be a bit weird if there was. So exits are at the back of the hall, straight out through the main entrance. And all the doors that have got little sort of locks on will be opened. There's also fire exits there and there, but I think we'll get a steer as to which gates we go through. We'll go through that one, and you assemble on the area in front of the school. Toilets, if anybody hasn't spotted them yet, are through and on the right of the entrance that you came through. So the purpose of the meeting, well, you've got the notice, and what we want to do is begin a dialogue about the sort of service we need in the health service and social care, what we need and want, what it might look like, how it might be run, and how we can have real democratic involvement in decision-making nationally and locally. And we want you to go away from this conference much more confident about the issues and what Labour would do, and be able to have those conversations with others, work colleagues, neighbours, people on the bus, that is going to be necessary. It is a conference run by the Labour Party and Unite, and we want you to be able to go out and feel confident when you talk to others about what the Labour Party would do. So how are we going to get that information across? Well, we've got 4 experts here. You've got their biographies in your pack. We've got Lord Philip Hunt, Shadow Spokesperson for Health. We've got Councillor John Cotton, Cabinet Member for Health and Wellbeing. We've got Professor John Glasby, Director of Health Services Management Centre, School of Social Policy at the University of Birmingham. He's providing us with the facts and the information that he's been gathering, so this is really helpful. And we've got Gerard Coyne, West Midlands Regional Secretary for Unite the Union, giving us, if you like, the workforce point of view, but also they've been running a campaign on TTIP, Transatlantic Trade and Investment Partnership. There's a few TTIPers here, I think, and I'll cover that as well. So we've got this welcome pack for you on your seats, and that's got some useful charts and articles to take away, and also, as I say, the biographies of our speakers. And there's going to be some follow-up, the scope for you to carry on this debate with others with similar interests, and you can use the form in the welcome pack, or just speak to somebody at the desk to, if you leave your email address, you can actually get the follow-up. So we've got our 4 experts bringing their different perspectives. They're going to speak for 10 minutes each. Then we throw the discussion open. And we're going to give you 1 minute to ask your question. That should be ample for a question. Or 1 minute to make a point. So we want these points to be concise, the more we get. We've got roving mics, so we've got our roving mic people will take probably 3, maybe 4 questions, and they'll be answered en bloc. And we're going to be videoing this, so we'll be videoing, having the speakers videoed, and also you in the audience. And that's so that we can have this as a record and a resource for later. It'll go onto websites in the Labour Party and Unite, and it means that if you leave us your email, we can have the links to it. So there's going to be something for you to follow up afterwards. So it doesn't just end here. This sort of starts here, really. So let's make a start here, and we'll have a wrap-up at the end. We're going to go on until probably about 8:45. So I hope that you have an enjoyable conference. I hope it's going to be a friendly and cheery and pleasant conference as well. That's the idea. So let's start. We're going to start with Phil Hunt, who's going to give us, if you like, the policy and the proposals from the Labour Party.
Okay, well, thank you very much, Rosie. Hi, everyone. It's great to see so many people here. And there's no doubt that 67 years after the formation of the NHS, it faces a critical moment in terms of its future. I think most of us, one way or another, have got a lot to be grateful for about what the NHS has achieved through that time. But I don't think anyone can be in a doubt as we get towards the election that there are some very critical challenges that it has to face up to. I mean, first of all, clearly as the population grows older, we are seeing many more people with complex care needs in one way or another needing help from the NHS. We're also seeing, I mean, there are huge potential advances at the moment going on in health technology, in medicines, particularly individualised medicines and treatments, all of which offer huge potential, but potentially could be very expensive, certainly in the near run. We also have huge inequalities in health and a really worrying increase in disease levels. I think most people now know that if you take Birmingham as a whole, you will see a 10-year difference in life expectancy of boys or girls being born today, depending on which part of the city they live and what their background is. What's also inescapable, when you've got figures like, John may correct me if I'm wrong, but I think it's 24% of young people in Birmingham are obese. School-age kids are obese. And we know that in 20, 30 years' time, they will be presenting to the health and care system with some really serious illnesses. And we know that unless we start to turn this around, we are going to have a system that is just going to fall over because of the likely demands being made upon it. And so just when the NHS is facing all these big issues, when it needed stability and leadership and support, what of course it's had in the last 5 years, is first of all a totally unnecessary but the biggest restructuring it's ever gone through. And alongside it, it's had a funding squeeze. Since 1948, the NHS has had 4% real terms growth on average every year until 2010. And then it's flatlined at about 0.25% real terms growth during this 5-year period. And the pressure on services, the King's Fund estimate, is still going up by 4% a year. So it's had a pretty massive reduction in real terms, alongside swinging cuts in local authorities. And because the biggest discretionary spend a local authority has in adult social care, it's not surprising that adult social care has taken such a hit in its resources. And alongside all of that, the health service has had a huge amount of time taken up, because the 2012 Health and Social Care Act really forced them to tender out services. And up and down the country, clinical commissioning groups have been wasting millions of pounds passing services up, putting them out to tender, some of which have now been won by the private sector. But even where it's not been won by the private sector, there has been a wholesale waste of energy and resources. The result of all this is pretty obvious. I mean, the targets are being missed. The 4-hour A&E target has been missed now for 82 consecutive weeks. The now called the University Hospital of North Midlands has been the worst performer consistently in the last few weeks. It's around 64% A&E target, a massive miss. We know waiting times are going up. There's huge pressure on the system. The closure of NHS directives, replacement by 111, where qualified nurses were replaced by call centre staff, whoever hard they work, inevitably has been pushing more people to A&E. We know, I think, all about the pressures in primary care, the problems in out-of-hours services, and because more people are going to hospital, there are less beds for them, and hospitals are finding it very difficult to discharge patients because social care is not being able to support people who need discharge. No wonder the whole system seems to be falling out. And the Nuffield Trust, which is an independent body that's been commenting on this, concluded about 4 months ago that patients are being forced to wait on trolleys because the pressures mean there aren't beds for them. Improvements in GP consultations have gone backwards. Planned surgery and A&E departments in general, the improvements we've seen over the last 10, 15 years have gone in reverse. And it's getting harder for children and indeed adults to access mental health services. And the King's Fund, which is another independent body, came out with its conclusions on the so-called reforms. I never use the word reforms, I call it the Lansley disaster. They came out last week with their conclusion, and King's Fund kind of always modify their language, but what they said is historians will not be kind to the coalition's government's record on NHS reform. They said they produced an unwieldy structure with leadership fractured between several national bodies, a complex regulatory system, and a strategic vacuum in system leadership at local. In other words, at local level, there is no one responsible for the health system in Birmingham. There are lots of organisations, lots of chief execs, lots of chairs of these organisations, but there's nobody you can finger to say it's your responsibility in terms of Birmingham's health service. And the other thing the King's Fund said is the emphasis on competition has resulted in greater complexity, uncertainty about when contracts should be put out to tender. So when they also said that the percentage of contracts going out to the private sector has remained constant, what they also said is sheerly the effort of having to put services out to tender has been an enormous drain on the health service. If the Conservatives win in 2015, expect more of it. More services we put out to tender, more fragmentation, no leadership, and the system almost working against trying to integrate services. So there is a real choice here. And what we in Labour want to do is to actually go back to 1948 and, if you like, complete the reforms that were started then by combining health and social care into one service, so that a lot of the barriers that we see at the moment, a lot of the perverse incentives that are in place, so that you can have a bizarre situation where the funding formula for Birmingham City Council will give extra money for certain characteristics in the city, whereas the health service will have a different funding formula which will take that money away again. And with each organisation only concerned with their own organisation and their finances, you can often find people arguing over patients because they don't want to pay the cost of care. And all of this detracts from having a proper integrated service where you build it around patients and the public, and where all the professionals concerned actually get their act together and start to provide a much more cohesive service. So we see this as being a health and care system under the leadership of the local authority in the Health and Wellbeing Board, combining budgets and making sure that everyone works to the same cause. Alongside that, nationally, we want the Department of Health and the Department of Community and Local Government to work together, and that will be unique in the history of government. Those two departments actually combining their effort and their resources, so that from the centre they are saying, we want you to bring your services together and we will support you to do that. And finally, we have to have a proactive public health programme. The rising tide of ill health is not sustainable. 12 years ago, Derek Wanless produced a report, and he said that unless we fully engage the public in promoting better health, the system is going to fall over. It's my contention we are beginning to fall over at the moment. And we have to be much stronger about things, particularly in relation to children, about food, sugar and salt in their food. We have to actually be much tougher with the companies about what they do to our food stuff. We have to be much tougher too in relation to things like standardised packaging for tobacco. And we also, and this is something my boss Andy Burnham is passionate about, have to get back to a situation where young people in particular do get opportunities in terms of physical activity to actually encourage them towards better health, both when they're young, but also throughout their life. And so combining health and care, making it integrated, getting rid of this wretched 2012 Health and Social Care Act, getting rid of the enforced privatisation, and putting a lot more effort on improving people's health. That, I think, is the way we need to go forward in the future, and it certainly will form the core of what Labour will offer the public at the election. Thank you.
Thank you, Phil. Right, I'll now ask Professor John Glasby to give us some of the factual basis for all of this.
Yes, thank you, and thank you very much for inviting me to be here tonight. Rosie's asked me in particular to talk about that integration of health and care, and about the evidence base behind what works and what doesn't when we talk about integration. But I also wanted to start with 3 or 4 initial points, just to place some of your subsequent questions and the debate tonight in a broader context. And the first of those is that the NHS and the services it delivers really matter. Now, I know you know that because you've come out of an evening in great numbers to have this debate. But actually, people have described the NHS as the closest thing that Britain has to a national religion. The NHS is with us from the cradle to the grave, and it's with us at some of the best and at some of the worst times of our lives, the birth of a baby, the death of a loved one. And when it gets things right, it can deliver care with amazing compassion, and it can reach to the very edges of what's possible in terms of science and beyond. Equally, when it gets things wrong, the damage that it can do can be irreparable. So actually, the issues that we talk about tonight and the questions that you ask and the actions that you take as a result really, really matter. These are quite literally matters of life and of death. Secondly, the issues are really, really complicated, partly because the NHS is so complicated. And one of the reasons for that is because it's so incredibly big, which I know is a self-evident, a fairly obvious point to make. But you've got some of the stats in your packs, and you'll see that they reckon that the NHS treats about 1 million people every 36 hours. My maths is pretty shaky, but I think by the time this meeting ends, the NHS will have treated 55,000 more people than it had treated when we started. It's got a budget of about £110 billion, and it employs 1.4 million people. It's often said it's one of the biggest employers in the world outside of the Chinese army and the Indian Railway Service. If it was a country, the NHS would be the 30th largest country in the world. And outside of the banks, if it was a FTSE 100 company, it would be the 3rd biggest in the world, just behind Shell and BP. So when we talk about the NHS as if it's a single thing, it masks an incredible amount of complexity because the organisation is so big and so broad and so far-reaching. The third point I think I'd make is that despite the media reports and despite some of our political debates, actually, the NHS still does really well in many, many respects. Again, you've got the data in your packs, but with the Commonwealth survey last year that looked at the quality of healthcare services in a number of different developed countries, the NHS came out as the best in the world. It came out as the best overall. It was the best in terms of quality. It was the best in terms of access. And it was the best in terms of efficiency. And I'm not sure those are things that members of the public would naturally have said of their local health services. By far the worst service anywhere in the world in that particular study was the US, which did dreadfully on all those different criteria. And actually, when you look at the data, there's quite high levels of staff satisfaction in spite of the very real pressures we're facing. And there's very high levels of patient satisfaction, both from the broader public, but also from patients who have recent experience of using health services. And typically, recent patients are even more positive about the NHS than the general public. So if you ask most of us, we say the NHS is pretty good. And we may have got our impression of that from people we've talked to, or from the papers, or from neighbours, or from friends. If you ask people who've recently used it, they say it's really, really good in terms of the quality of the care that it delivers. Despite that, though, as Philip said, there are some significant problems. We've had a series of care scandals in recent years that have underlined what can go so drastically wrong sometimes in our services and in our systems, and the need to improve quality and safety and to learn what to do differently and what to do better when things do go wrong is crucial. Philip mentioned funding issues as well, and those are really significant both now and going forward after the election. The NHS has estimated that because of the pressures it faces, there will be a funding shortfall of about £30 billion by 2020. Now, the service thinks it can make up £22 billion of that total by productivity savings, which feels optimistic to me. But it's asking the public and the political parties for the remaining £8 billion. Now, all the main parties have put forward proposals about the funding that they would provide, and there are some similarities and there are some differences. As I understand it, they're all quite a long way away from that £8 billion gap that the Health Service is saying that it needs just to stand still. And whoever wins the general election, what we do about that funding gap in the short and the medium and the long term will be crucial, as Philip highlighted. We've definitely got a very fragmented system. Part of the difficulty at the moment is because nobody's in charge. It's actually quite hard to get anything done in response to some of the pressures that we face. And we also have a need to rebalance the services that we've currently got. And debates like this one tonight can be really important there because there are two dual pressures. Some of the services we deliver are very, very specialist and very complex, and they're probably best provided in quite large, quite centralised regional services where you can concentrate all the expertise that you've got and where we can have 24/7 access to those skills and to that expertise. And that might mean some local services having to give up some of that expertise to a more centralised regional service. And at local level, that can feel and look like a cut. It probably isn't, actually. It might be about trying to make best use of the expertise and the skills we've got by centralising some of it in a regional setting, rather than actually a reduction in service. And how we engage in those debates as a society so that we can ask critical questions but engage constructively with those debates rather than say, well, not in my backyard, hands off my local services, will be really, really important. Equally, we've got a number of services that are based in hospitals at the moment that might actually be better placed in the community or indeed in delivering care in people's own homes. And although it's really important we've got high-quality hospital services when we need them, the bulk of people using the health service are actually sometimes people of working age, but often older people who have multiple chronic diseases or long-term conditions, things like diabetes, breathing problems, heart problems, depression. And the highest users of health services tend to have 5 or 6 of those conditions at once. And if they have a crisis in their healthcare, they need to be in hospital. But the bulk of the care they need is more around supporting their own health and managing their own condition at home, and its support in primary care and in the community. So if some services would be better placed in the community and in people's own homes, and some services would be better placed at a kind of regional level, there is a dilemma in some parts of the country for some hospitals that provide both those kind of services at the moment. And again, we need to be able, as a public, to ask the right kind of questions of those processes so that we're not being fobbed off, but we're engaging constructively in those very difficult and very emotive discussions. And as Philip said, one of the solutions that's being put forward in the current context is the promotion of more integrated care, particularly between healthcare and social care. And most members of the public think that health and social care are part of the same system, that they're organised and funded in the same way. And it's typically only when people are in crisis and need quite urgent support that they find to their cost that those are quite different systems and that they operate and are funded very, very differently. And for many older people in particular, when I was practising as a social worker, there was a real sense of betrayal that the system they thought would care for them actually was more complicated than they realised. And going back to the 1940s, we've got a system in this country that assumes it's possible to distinguish between people who are sick, who we label as having healthcare needs, and their services are provided free at the point of delivery by the health service, and people who are somehow merely frail or disabled. And those are people we label as having social care needs. Those are the responsibility of local councils. And people are means tested and charged, sometimes very, very significant charges for the cost of that care. And I'm not sure if breaking the world down into health and social care categories ever made sense. But in the early 21st century, given some of the demographic changes that Philip described, it increasingly feels like it doesn't make sense any longer. And we probably need a more fundamental rethinking of the boundary between health and social care. The tricky thing is how to actually do that in practice. And we've been trying, in one sense, ever since the 1970s to do that without ever quite cracking it. Places like Northern Ireland have had much more structurally integrated services, again, since the 1970s. And yet the reality of services in Northern Ireland is that they don't feel much more joined up than our services do here. Because out of that original distinction between health and social care, you then have a series of different organisations with different legal frameworks and different budgets, with different geographical catchment areas, with different IT systems and different ways of training and educating practitioners and managers, a series of sort of practical and structural and cultural barriers that flow out of that initial distinction that are very, very difficult to overcome at local level. So arguing that we need to more fully integrate care is 110% the right thing to do. Being clear exactly how you do that and how you do it for real and how you do it in Moseley on a Friday afternoon when it's raining, is really the acid test of turning that vision into reality. And in particular, the evidence base is fairly discouraging about the extent to which it's possible to do that quickly or the extent to which it's possible to release significant savings from doing that. There's quite a famous article called The 5 Laws of Integration, which people can Google if they're interested. And one of those laws is that integration often costs before it pays. I think I'd probably add a bracket to that law, that integration often costs before it pays, brackets, and we typically never stick at it long enough to work out whether it ever really pays, close brackets. So there's some really important work to do and some really important work to do together, but actually turning the vision into reality, given those historical, organisational and cultural divisions, really is the key. And in one sense, local services have been trying to do that for many, many years. We're a lot further forward on now than we were some years ago, but we're still quite a long way away from actually delivering it in practice. And probably what's important for me and what I'd be keen for us to debate tonight is the extent to which it's actually possible to integrate care in the current structures. Another of those 5 laws of integration is that it's quite difficult to integrate a square peg into a round hole. And we found over time that it's very, very difficult to try and integrate care in a system that wasn't designed with integration in mind. And so what's more important for me than the specific mechanisms we explore is probably the broader debate that we have as a community and as a society about the kind of services that we want to have together, about the kind of life that we want to have together, about how much we're collectively and individually prepared to pay for that, and then about some of the practical mechanisms that we might put in place to pay for it. Because a lot of the options that are considered from time to time are often bandied in the media and in some of the sort of Prime Minister's questions as being unaffordable, as if that's an economic argument. Whilst actually saying something's unaffordable is a political statement, because something's only unaffordable if we're not prepared to pay for it. Actually, we could do 101 of the things we might talk about tonight if we were prepared to make some very difficult choices about some of the other things that we wouldn't do in order to free up the money. So the vision is important, the specifics of how you do it is important, but actually having that prior debate about what kind of services do we want, what kind of life do we want to have together as a community, and to what extent are we prepared to pay for it, feels a more fundamental debate for us to be having, so that frontline services are then freed up and empowered to deliver on our behalf the integrated care that we say we want.
Thank you very much. Right, well, thank you very much, John. And now we've got John Cotton, who's actually got the task, potentially, of doing just that, were Labour to become the government next. So, John, tell us what you're going to do.
Always love it when the bar's set high by the chairman. There's 4 things I think I'd like to cover in the context of my remarks. Firstly, just to set out the context of Birmingham and some of the health challenges that we faced. Then to set out some of the challenges that we face financially as a local authority and the implications of that. a little bit about what we're trying to do in the current context of that very disjointed health economy, and also to offer some comments on where I think we might get, should we get a Labour government elected in May, and be able to respond in a very positive way, I think, to the plans that Andy Burnham and his team have set out. But my starting point is, if you look at Birmingham, and I think the facts around health in this city spell out in the starkest possible terms the degree to which there is severe and significant inequality that still scars too much of this city. You know, there's a lot of statistics you can trot out around unemployment, around educational attainment, low pay, but I think the health statistics are the most striking of all. I don't think anything can illustrate inequality more starkly than the fact that you can add or subtract 10 years to your life expectancy simply dependent on the postcode in which you live. That sets out the scale to which this is still an unequal city. The fact that those are the places where you're more likely to be, well, less likely to be physically active, more likely to eat poor food, more likely to smoke, more likely to develop those kind of chronic conditions that then create real health problems and frankly, you know, die younger. So I think tackling those inequalities has to be our absolute core mission as a city, and ensuring that we're removing those barriers to people living a better and a healthier life. And that's very much core business for me as the Cabinet Member for Health and Wellbeing. I've got responsibility for adult social care, I've got the public health stuff, I've got the supported housing and homelessness piece, and also I chair the City's Health and Wellbeing Board as well. So this is absolutely central to our mission. So we know we've got a really ingrained, well-established pattern of inequality, and that would tax our resources to deal with, I think, at the best of times. But as Philippa said at the start, we're trying to deal with this in the context of some of the deepest and most savage cuts to local government budgets in living memory. Local government and welfare, very much the front line of the health and social care system in this country, have borne the brunt of those cuts that the coalition government has brought through since they came to office in 2010. Now, for Birmingham, that combination of those cuts, plus the pressure that comes and more people needing our services, that means we're looking at having to take out something around the region of 800 million from the council's controllable budget. It's around about 60-odd% between now and between 2010 and 2018. In the next year alone, we're having to find another 200 million, and that's on top of the 460 million that we've already had to take out. And of course, what's made it worse for Birmingham is the very unfair way in which those cuts have been loaded. They leave the urban areas, big cities like ourselves, at a severe disadvantage. Because of our issues around deprivation, we're far more reliant on central government funding. So, if I take you through the budget, 67% of the City Council spending is funded through government grant. Only 8% of what we spend comes through the council tax that we raise locally. So when those cuts come, we're really exposed and incredibly vulnerable. And the way in which they've been apportioned so unfairly means that the cut in our spending power this year is equivalent to £147 per dwelling in the city. That's at the same time that some authorities in southern England, I have to tell you, some areas here redolent of deprivation, Windsor, Maidenhead, Buckinghamshire, Wokingham, which has become something of an old friend if you've been to a number of meetings recently, they're actually seeing an increase in their spending power when we're seeing ours cut. So you have to ask, where is the fairness there? So faced with that situation, we know that we can't handle those pressures in the way that we traditionally have as local government. We used to call it salami slicing. You take a bit off here and a bit off there and manage to muddle through that way. We're in a very different space now, and I think, Albert Bohr, as leader of the council, was quite right when he said this is the end of local government as we've known it, because that's the situation we're now in. So we've got pronounced inequalities at the very time we desperately need those resources to deal with those and the capacity to support the most vulnerable. We're being frankly cut to the bone. And it's rather worrying when you see George Osborne's pronouncements about what might happen should he carry on as Chancellor after May, where clearly local government and welfare are in the front line again. They'll be the target of that next stage of the austerity drive, and frankly I think that would push an already tottering system of social care in the city over the edge. So it's a rather grim picture that we see. But despite the cuts and the fact that we get some money from the NHS in the city, about 25 million, this is so-called Section 256 money to underpin social care, we've managed to maintain our obligations to meet our statutory duty, to meet the care needs of those who are in critical or substantial need. But to put that into context, they're the people who have the most profound and pressing care needs. So we've got 140,000 people in Birmingham who are aged over 65, but the council's only providing funding packages for about 10,000 of those people. And around under 3,000 of those are in permanent residential or nursing homes. And there's a similar picture if you look at the care for younger adults as well. Now, the pressure on those services is going to continue to grow, partly because of the finances, but also the demography of the city. So we expect to see more people in the coming years presenting with those critical and substantial needs. If you just look at the statistics around dementia in the city, for instance, we expect the number of people with dementia to grow by 20% over the next 6 years. So that's another potential pressure that's building up for those care services. Now, I think the sensible way that you try and approach that pressure would be to try and stop the things that lead to people needing that kind of intensive care, that very expensive care provision. Trying to prevent those causes of chronic ill health, stepping in and helping people earlier, whether that's get through enablement, whether that's using assistive technology, or just simple social care support and improving local activity. That's obviously better than waiting until people get into the state where they have a critical or substantial care need. Certainly better for them, and of course it's better for the public purse as well. But the conundrum and the challenge that we've got is that when your budgets overall have been slashed so heavily and you're struggling to meet your obligations to those who need the most intensive support, finding the money to invest or sustain any kind of early intervention or prevention activity, which, unlike meeting the substantial and critical care needs of people, isn't a statutory duty, that becomes an increasingly difficult thing for local authorities to do. So we pushed into this rather perverse position, if you like, of having to cut the very things that remove the future pressure from our statutory services, simply in order to keep those statutory services going for the present set of citizens who need to use them. That isn't sustainable, it isn't sensible, and it needs to change. So what we've tried to do in Birmingham is at least protect some of that prevention work. So, for instance, we're still continuing to support housing-related support, helping vulnerable people to sustain their tenancies, to find work and training by retaining a good chunk of the Supporting People programme. In fact, we've been able to mitigate some of the proposed budget cuts to sustain support for younger adults with mental health problems as a result of some of our decisions this week. But I think things like supporting people are really important in keeping people away from that front line of social care. I've just come back from spending a few days in Staffordshire, undertaking a peer review of the social services there. This is an arrangement we have between the local authorities in the Midlands. They're actually taking their Supporting People programme out altogether. And having seen the evidence that's come from some of that, I've come back absolutely certain that we've made the right call in trying to sustain as much of that activity as we can. We're also trying to do similar things in terms of keeping some money flowing into the voluntary sector for those community-based activities, the things that tackle isolation and loneliness, which frankly can be as destructive to health as some of those other physical conditions. And creating the opportunity just to bring people together is frankly a far better way in most cases than trying to medicalise the problem and issue medication. That's the kind of approach that we've tried to weave into Birmingham's Better Care Fund plan. This is the approach that's been taken nationally at the moment to try and do some of that health and social care integration that John referred to. So we're trying to work and pull the council's money and NHS money to sustain and increase that kind of preventative work. But I'm also really keen that we don't just limit our approach to health issues to silos. So you've got one that's called social care and you've got the one that's called NHS. As a local authority, we've got other powers and other influence at our disposal as well to drive forward that health agenda, to shape the environment and encourage healthier behaviours. So what we're looking to do at the moment is to apply a public health test to every aspect of council decision-making and policy. At the moment, we always look at legal implications and we look at the equality implications and the financial implications. But actually, we need to look at every act and ask the other question. Does this decision, does this policy encourage healthier behaviours? Does it increase physical activity? Does it maximise people's mental well-being? Does it encourage those healthy behaviours? Does a planning proposal encourage more people to walk? We know that walking is probably one of the most beneficial things you can do for your health. Are we using our licensing powers that we already have to our full effect? And I'd hope to see some more licensing powers come through to local authorities if we get a Labour government later this year. So, can we build on some of the work we've already been doing to restrict the growth of fast food outlets? So really hardwiring that kind of public health approach, maximising the ability to ensure people can live that kind of healthier lifestyle. So, just to touch on the obesity issue for a moment, which I know, Philip, you referred to earlier. 1 in 4, that's a quarter of Birmingham children, are not just overweight by the time they leave primary school, they're actually obese. And the long-term costs of that for their own well-being and indeed for the kind of conditions they will generate and the pressure on the health system, that's huge. Cost to the system that we reckon by 2050, if we carry on the current trajectory, obesity will amount to 2.6 million a year cost to Birmingham. So, that's why we need to hardwire that public health approach into what we're doing. So I think we've made a positive start in some rather difficult circumstances around some of this in the city. And I think there's certainly a shared will between the council and partners in the NHS to try and make this happen. But without extra resources and without a clear mandate to lead that fractured health and social care system, we can't deliver all that we want to and to try and really turn around that picture of inequality. So that's why I think the kind of proposals that have been issued in Labour's 10-year plan for health and social care are so absolutely welcome. I think there are 3 things I'd just flag up as particularly important here. One is that recognition that what goes on in a hospital depends on what goes on in the community. I think it acknowledges that fundamental truth that prevention is far, far better than cure, not just for the taxpayer, but for those individuals who are a better place to enjoy an independent and healthier life. Second, the fact that the plan tries to achieve that by ending this destructive and counterproductive division that we've got between the worlds of health and social care, trying to get away from that, having 2 systems running in parallel, or at worst in conflict at times. We're trying to build that single approach and bring those services together so they meet the needs of the individual rather than the institutions. And I think we've got an opportunity to build on that work we've already done in Birmingham to do that. But I think it also seeks to do that by delivering and observing a very important third key principle, which has already been touched on. Over the last 3 or 4 years, we've seen how destructive top-down imposed change can be to the system. That has just wreaked havoc throughout the health and social care system. And it's really debunked, I think, this idea that you can re-engineer the system from a room in Whitehall. That's been completely thrown out by our experience. What you need is local leadership, you need local decision-making, and you need an element of local choice. It should fall to Birmingham, frankly, to decide what Brummies need and how that is best provided. So I think the fact that the proposals seek to really strengthen the role of the Health and Wellbeing Board, giving it that clear mandate to lead that disjointed system is a really positive step forward. It gives us the opportunity to really drive forward the integration and ensure that we've got a combined health and care budget. So I think there's some real positives that we can build on there. Just leave you at this point. I think the next few weeks, the next few months are going to be absolutely crucial in determining the long-term future of the health and social care system in this city. And the decision that you as voters make in May will determine, frankly, whether we keep trundling on towards what I think is a huge disaster in the making around social care in this city, whether we continue to see further savage cuts in frontline local government budgets and continue to see this chaotic NHS structure there. That's the one option, or we've got the other option to do something that's genuinely focused around prevention, end some of those divisions between the system, and enables us to further drive forward a process that will ensure that we prevent the causes of ill health and really get back to tackling some of those inequalities that we know that the city faces. Thank you.
Thank you very much, John. And now hand over to Gerard Coyne to talk a bit about the workforce issues and TTIP. Or anything else, actually, John?
Thank you very much. I'm going to be talking on some broader issues, and then I'll focus in on TTIP for a while and perhaps also pick up in questions a bit more detail in relation to some of the workforce issues as well. Firstly, can I say I'm really pleased to be involved with tonight's event. Certainly we've been working closely with Moseley and Heath Ward Labour Party to establish this event, and you might be somewhat surprised that it's Unite that's engaged in this, partly because you wouldn't possibly necessarily expect Unite to be a union that has a lot of involvement in the health service. when you see things on the telly about the NHS, more often than not, perhaps it's a Unison or an RCN rep that is quoted on those interviews. You may be surprised to know that Unite has 100,000 members in the NHS in a whole range of different areas of specialisms, from speech and language therapists through to community health visitors. The blood service predominantly is Unite membership as well. But it's not just because we've got those members in the health service that it's important that we're involved in this discussion this evening. Unite nationally has 1.2 million members. And those 1.2 million members, to my mind, just like you in this room, are 1.2 million shareholders in the NHS. Now, I'm going to say a few things about private companies and their shareholders a bit later on, but I genuinely use that phrase shareholders because I think, just like everyone in this room, our members have paid their national insurance, they've paid their tax over their working lives, and they have contributed to what is their NHS, the thing that they have created, just like many of you in this room have done over many years. Perhaps a bit unlike HSBC, who have done a good job of hiding people's taxes rather than paying them. But also, potentially, as well as those 1.2 million shareholders, or same as everybody in this room, that is potentially 1.2 million users of the service, because for whatever reason, we all rely on the fact that if we step out of this meeting this evening and something happens to us, we know that there will be a blue light that will pick us up and take us to a local hospital if that's the care that we need. And that was absolutely the founding principles that the NHS was based on, that it was free at the point of need. So, along with other trade unions at the very start of the NHS, we were championing the idea and the principle that it should be free at the point of need, and that it was trade unions that were involved, along with the Labour Party, around the creation of the NHS. And we've had a stake in its past, and we hope to have a stake in its future, and this is what the discussion is very much about today in terms of what future for the NHS. I think you'd be genuinely quite staggered to understand that since the Health and Social Care Act came in 2012, just how much of the service that we think of as the NHS has been either put out to tender or is already being run by the private sector. You heard figures about the global total of how much the NHS, in terms of its revenue, is per annum, but already £10 billion worth of services, over £10 billion, has been put out to contract in such a very short period of time, and with little or no public knowledge of that fact. Unite last year commissioned research into those tenders and uncovered the depth of which it has been taking place. Most of the providers that have been involved in those tenders, the most successful ones, have been private sector providers. The NHS has won very little of the contracts that have been put out. So when David Cameron very famously in 2010 said the NHS is safe in our hands, I'm not sure there's that many of us in the room that believed him at the time. What he actually meant was the NHS logo, that blue and white logo there that's on the sign that we all associate with the NHS logo is safe in their hands, because you'd be staggered to realise about the number of services now that when you go into an NHS hospital that you think, and it's got the blue and white logo there, they're actually being delivered by Virgin Healthcare, by Nuffield, by a whole host of other organisations, but the logo is fronting that contract. So you think it's the NHS, but actually the provider behind it isn't. And that's something that we're experiencing very much so in some of the fights that we're involved in as Unite within the West Midlands region about some of those contracts that are being put out. Philip Hunt mentioned earlier on about Stoke and North Staffordshire and the cancer and end-of-life contract that's currently out for tender up in that area of the region. This is a £1.2 billion contract over 10 years. And once it's let, it commits the people of Stoke and North Staffordshire to a provider without a break clause. There is an integration period for 2 years, but once that 2 years has gone by, for the next 10 years, they are committed to that provider, whether it's good, bad or indifferent. There is no break clause on that contract. The process by which it's been put out to tender has been shrouded in secrecy all the way through. Believe it or not, the CCG and the Chief Executive, Andrew Donnell, who's leading this, has said that they've carried out consultation, and their version of consultation is actually sending a letter to GPs. Not one single public meeting has been called by the CCG in the past 7 or 8 months that this tender process has been running. So the people of that area, like you tonight, have not had the opportunity to come to a meeting that's been called by the CCG. Thankfully, the community up there, an organisation called Cancer Not For Profit, has been very active in making sure that people know that this proposal is taking place. And they've got over 14,000 signatures on a petition to try and stop this privatisation taking place. There has been a great deal of discussion with the clinicians up there, the local authorities, with the community at large, and overwhelmingly, nobody sees the logic for this service being privatised. At the moment, as it stands, there are 5 private sector companies that have been shortlisted and 2 NHS providers. But nobody seriously thinks that the NHS providers are going to be the ones that win this contract. And I just want you to think for a moment about the service that we're talking about here. This is some of the most vulnerable members in that community, people who are faced with that really traumatic reality that they have got cancer and that there is a limit on their life. The fact that actually out of the care, the cancer treatment that they receive and the palliative care, that profit should be made just seems obscene to me and to most of the people in that community. They think it should be delivered by people who have the patient's interests at heart, not the profit, the shareholders' interests that a private company has no alternative but to serve. So this is going on now as we sit in this hall, and you have to understand that there has been, dramatic activity already in terms of the privatisation. While the badge hasn't changed, the provider has. And this will get worse, not just in terms of what the current government have in their policy toolkit come May the 8th, sadly, if they win the election, but more importantly, some other things that are taking place. There is a discussion going on between the United States and the European Union at the moment about the Transatlantic Trade and Investment Partnership. Very long title, TTIP for short. We know it internally inside Unite as the Transatlantic Trade in Privatisation, because what it is actually about is allowing companies from over the other side of the Atlantic to bid into goods and services, and the services is the key bit, for contracts inside the European Union. Now, in some areas you might say, oh, well, that's okay, that's free trade, that's fair, that should be allowed. But what the government has kept very quiet through this process is the health service, our NHS, is one of those services that had been included in those TTIP negotiations. And what that would mean is that not just the private sector providers and some of the American arms of those private companies that already operate in healthcare in the US that are bidding in now, but it would mean that those healthcare companies from the US not only could directly bid in for those contracts that are happening in the NHS, but if they're not put out to tender, if contracts aren't fairly tendered in the competitive process, then they could sue the British government for failing to do so. So a private company could sue the British taxpayers for not opening our NHS to competition and privatisation across all of the range of services that the NHS offers. Now, we're working really, really hard and lobbying MEPs. We're working hard with supportive MPs and Parliament and community groups and others to make sure that that doesn't happen, and have kicked up a stink about it because those that were involved in the negotiations thought they would get it through on a nod and a wink. Mercifully, people have started to wake up and say that shouldn't happen, and you're now getting a number of people coming out publicly and saying they would oppose the inclusion of the NHS in TTIP. I am conscious of time, but I do just want to focus a bit on two things, really. One, to round off on an anecdote about how that privatisation has had a direct impact on people in this region. But firstly, I want to say a few words about what's been happening in the workforce issues inside the NHS. The Lansley disaster, as was termed earlier on, has had a major impact. That reshaping and constant churn of reorganisation in the NHS has demoralised the staff. There is no doubt about it. The freeze in pay has clearly added to that. And as you heard yesterday, the culture that has been developing in the NHS, a fear of whistleblowing, the ability to actually flag up when patient care is not what it should be, and for workers to be able to raise that and to have that taken into account and properly dealt with by management, has been squashed. And in most NHS trusts, it's a real issue for whistleblowers as to be taken seriously. But you set that alongside not just those who are directly employed in the NHS and the problems that they feel and the pressure they feel, but there is a burgeoning workforce inside the NHS that is not directly employed, not just those that are privatised. There is a massive growth in agency and locum workers in the NHS because of that restructuring and reorganising that was not well thought through, that has left gaps, and has meant that actually over the past 4 years, a staggering amount, £5.5 billion has been spent on agency and locum workers in the NHS just to cover those gaps that were put there because of fractured reorganisation and a failure to understand what the service really needed. And nowhere is that more apparent than perhaps in this anecdote that I want to round off with. A good colleague who I work with, his son sadly was taken ill, young son was taken ill with a hernia. And in a young child that could be quite a serious issue, and he took him into his local hospital, which was Russell's Hall. But sadly they'd not got the facilities in Russell Hall to be able to carry out that operation. They'd phoned the Children's Hospital here in Birmingham. They got a bed booked and the availability of a bed and a surgeon to carry out the operation ready and waiting. He'd gone in and was in the process of waiting some 4 hours for patient transfer. Patient transfer at that hospital has been privatised. It's outsourced. And in their contract, they cannot deliver to an A&E department. Now, if those of you who have used the Children's Hospital in Birmingham will know that sadly there is no other access point through the Children's Hospital other than the A&E department at the very front. Despite the fact that actually there was a bed booked for this child, so literally they were going to take him through on a trolley, through the A&E, straight through another set of doors and straight onto the ward, the contract stipulated that they could not deliver patients to an A&E facility. The result of that is he'd waited 4 hours. He then had to wait another 3 hours for them to pull a blue light ambulance off service, so taking it off the network of support to those who need it absolutely at the most. You know, blue light ambulance, emergency ambulance had to come off service to take that child from Russell's Hall to the Children's Hospital. Now, if that's not a story of a ridiculous Alice in Wonderland fragmented service inside what we consider to be our NHS, then I don't know what is. And we have got to do something about this. So thanks very much for the opportunity to address you this evening, and I look forward to the debate now.
Right, well, this is now the time for you. So we've got some roving mics, and we just need some speakers, okay? I'm going to take them from different sides. So you at the back, and then Dave Spilsbury. And then chap over there. Yes, okay. Dave Spilsbury, put your hand up.
Hello.
You've got 1 minute.
Hello. I'm Stuart Richardson from Left Unity, and we've had some very interesting comments, particularly by the professor, that none of the parties are providing the funds to balance the books. Even John Cotton, a leading member of the Labour Party, said that we need more resources. The problem is, and it's actually in a newspaper here, Ed Balls is saying we will not reverse the coalition cuts. More seriously, he's recently said that he's been examining how to balance, how to increase expenditure for local authorities and can't find the money. And therefore, the massive cuts of hundreds of millions will continue in the local authority. Now, that's very important because social care is being massively cut, which is causing massive blockages. So it does seem to me that the promises of the Labour Party not to reverse the courts is going to make the deterioration. Just last one point, I thought it was Gerard's very good contribution on privatisation, but I think we need a critical assessment of the fact that the Labour Party started this process in a big way with the massive privatisation of PFI hospitals, which is leading to almost bankruptcy of many services because they can't pay the interest. Thank you.
Okay, thank you. Right. Next speaker, and then we'll... So,
okay,
David?
Thanks. My name's David Spilsbury. I'm an ex-member of the Labour Party. I don't always agree with Stuart, and in this case, I partly agree with what he's saying, but from a rather different perspective. Instead of always criticising the Labour Party, I think it's important to give support to the development of Labour Party ideas. What concerns me is the way in which there is a danger that we go into this election with the Labour Party committed to making no top-down reorganisation of the NHS. Time and again, we go into elections where the Tories have ideologically shifted the balance on all manner of things, trade union so-called reform, for instance, and things like that. And a Labour government then comes in committed to doing nothing about it. Now, it seems to me it's very important that we do actually say, and Andy Burnham, Ed Balls, Ed Miliband should be saying that we will change the NHS because what they've done over the last 4.5 years is so appalling, it's so against the best interest of the public.
David, you've had your minute, love. Right, bloke over there.
Mark Odey, I'm a UCU regional official and I'm former active member of the Community Health Council in North Birmingham and a national advocate for RAGE, which stopped the closure of the 30 care homes in Birmingham and care homes all across the country. And good to see David here as well. Been a long time. 4 points, very briefly. Democratic accountability. Rosi raised a point about that. Philip Hunt was part of the movement that got rid of the CHCs. When can the public, in New Labour's policy, have any say in their health service that was stripped from them when the CHCs were abolished? Second point, social care. The 30 care homes in Birmingham were closed, ended up with a loss of nearly about 850 beds. RAGE produced 3 reports, all of which are available. From looking back in history now, that informs where the crisis we've got now in our health service in this city in relation to older people. In CAMS, Children's Health, the Patients Forum, which was then abolished by the Labour government and the Conservative Party later.
Can you wrap up?
Yeah,
You've got two more points, haven't you, to make?
CAMS services for children have got to be invested in, quite critical. And on Francis, the Francis report in Staffordshire only went part way. He never looked at the market, how the re-regulation by the state of the NHS demolishes healthcare and also changes the ideology of its workers, particularly its managers.
Okay, thank you. Now, come to the panel now answer those. Thank you very much. So, be they taking it? Who wants to do the?
Don't mind to talk. Yeah. Shall I go first? Or?
If you want. Yeah.
Yeah, I'm quite enjoying this actually. I thought at the panel it'd be me that was the target for some of the more detailed questions, but from the tenor so far, I think it's some of the other panellists. It was quite good fun listening to some of that. The one I'll pick up on is about the whether or not we should about reorganising the NHS. Should we say no more top-down reorganisations, or should we actually say no? If it's wrong, we should change it. The note of caution I'd sound there is that the evidence base around the impact of major structural changes is very, very clear. And over time, in many sectors, in both the commercial sector actually as well as in the public sector, it suggests that large-scale structural changes by themselves seldom achieve stated objectives. They tend not to save money. And they tend to make things worse rather than better, normally for about 18 months to 2 years after the reorganisation, if you manage that reorganisation well. If you don't manage that reorganisation well, then the negative after effects can last a lot longer. Because effectively the structural change that you bring about becomes an end in itself rather than a means to an end. And people often feel so threatened, particularly in terms of their jobs, by the changes, that they focus much more on their own well-being and their own immediate concerns rather than taking broader accountability for the quality of services. So if it was me, if I were Health Secretary, I would make NHS reorganisations illegal as a policy pledge. They look big, they look bold, they look as if you're sweeping away and ushering in the new. They're very tempting in that sense as a kind of quick fix. Actually, over time, it's often proved that they make things worse rather than better. So for me, it's more a question of trying to deal with the structures and the systems you've got whenever you've got responsibility for them and trying to work out how to improve them rather than the Big Bang kind of approach. And there's a really good summary of some of this from an organisation called the NHS Confederation that you can, I think, download for free. And the best thing about the report was the title, and it was just called The Triumph of Hope Over Experience. It's that belief that there's a perfect organisational structure out there. It's just we haven't found it yet since 1948. And perhaps if we keep going, the perfect organisational structure is one more reorganisation away. So actually, while it's tempting, I'm not sure structural change is the answer.
Thank you. Hand over to Philip.
Yeah, I mean, look, it's fair enough. You want to criticise what a Labour government did on health, fine. You're entirely able and it's proper for you to do it. But I would just say to you that you should know who your enemy is. And I'll tell you, if the Tories win, because some people don't vote Labour at the next election, the health service is going to be in a parlous state. But I will respond to those issues. On Stuart, I mean, what Ed Balls has said is we are still committed to cutting the deficit, but we will do it on a slower rate. And that means billions of pounds available for public expenditure. It doesn't mean it's going to be easy. I wouldn't pretend it's going to be easy, nor does it mean there are some public services that are going to find life very difficult. But we started to identify additional money for the NHS. It's called a Time to Care Fund, coming partly from the mansion tax, partly from a tax on the tobacco companies and partly on more efficient tax gathering, which will be the start. I know it's not all of it, but it will be the start of an investment fund to enable you to make the changes in order to get integrated care up and running, taking John's point. The second thing is privatisation. Why did we use some private sector hospitals to get the waiting lists down? We got waiting times down from a target the Tories had, which was a maximum of 18 months for treatment, which they never ever got to. We got that down to 18 weeks. and we used the private sector to help us do that. But the NHS was in the driving seat, and this is the big difference. It was entirely up to people in the NHS to say, if we needed extra capacity, we will go to a private hospital. What's happening at the moment is millions of pounds are being wasted on forcing tendering of all these services with dire consequences. I mean, we haven't time to talk about Staffordshire, but there is so much going wrong in Staffordshire. It kind of shows what will happen to the rest of the system. North Staffordshire Clinical Commissioning Group has decided in its wisdom that if you need a hearing aid, you will only get it in 1 year. And they're making all sorts of bizarre decisions like that, including on the point that Gerard made about end-of-life care and cancer services, is the CCGs are handing over the commissioning of services to the private sector. So for 10 years, they will have transferred their responsibility for commissioning over to a private sector. That's what we've got to go for. Of course, you're right about community health councils. We shouldn't have got rid of them. It was a mistake. Nothing that's been replaced them has been effective. And I think locally, even in Birmingham, with the local health watch, is now in some difficulty, isn't it? I think they've sacked the governors, haven't they? The people who run it. So it's in a mess. I don't think the last thing we need to do is come up with something else. I think what we've got to do is try and work with local health watch to make them much more effective. And just to David, I totally understand what David means. There is nothing I would like more than to rip up this whole ludicrous structure and start again. It's just that we've been told by people in the NHS that it's the last thing that they can cope with if we do that. We haven't got the money. We can't afford £3 billion to be wasted on another restructuring. And we are going to enter the Department of Health on May the 8th in a total crisis of money and worrying about next winter because of what's happened this winter. So what we've got to do is to basically let people locally make their own adjustments to make the system work better, where you can then get local accountability. And in the end, someone has got to take charge of the system. The key thing, though, David, is that we will get rid of Part 3 of the 2012 Act, which is all about enforced competition. And we've already got a bill, the Clive Efford Private Members Bill, shows how we will take the NHS out of European procurement and competition law to do it. Yeah, absolutely. Absolutely.
Gerard?
I was just going to address the comments to the colleague from the UCU who's just about to leave the room. So, I think it is important, though, this issue of democratic engagement and involvement in the health service. And sadly, it's a reality of life, isn't it? When something is working to a degree and people get the service that they're expecting, the level of engagement is not as great as what we're experiencing with this meeting. It's the fact that we all know that this is in crisis, that we know that the reforms so-called reforms, haven't worked, and that actually we've got what we read in the newspapers almost on a daily basis that is starting to generate that level of engagement from us, the users of the service, that are actually the people that should be involved in the consultation and structuring process. And certainly I'll go back long enough to have had an experience of being around when the CHCs were there, and sometimes they were very valuable organisations, but equally I can be frank about the fact that sometimes they were a very smaller group of people that were not quite as representative as the community as they could or should have been. That wasn't a fault of that organisation. That was just the fact that actually people felt the NHS was safe at that time and they didn't have to come up and stand up for it in the way that you've turned out today.
Right, so more questions. Chap there. Lady there. Over there. Start with this bloke. Oh, sorry.
Thank you. Most of the changes in social care and healthcare have been ideologically driven by laissez-faire right-wing thinking. In the light of this, why isn't the Labour Party unequivocal in its condemnation of TTIP, which is a charter for corporate expansion?
you.
Anne Durbin, ex-paediatrician. I wanted to unpick a little bit this mantra of combining health and social care. Firstly, when we say combining it, we're talking about combining organisations, in which case is that not a reorganisation that will affect people's jobs, and people were saying who's going to run this, who's going to be my manager, just like we had over the last 5 years. And secondly, do we really mean combining health and social care for all age groups? Are we going to put children's social care in that mix? So the child protection services, the children's social workers that are failing in this city, we are told. Is that going to be part of this combination? Because it works very well for old people, but I'm not sure about it for children.
Okay, thank you very much. Okay, did you have your hand up? Yes, chap there, he had his hand up.
Hello, my name's Robert Punton. I'm a social justice campaigner and a Tusk candidate, but most importantly, I've been a person who has used services in this city for over 30 years. While we talk a lot about integration, and the new buzzwords are personal centred planning and personalisation, how do we ensure that we keep people at the centre of this thing, whilst we also talking about saving money? We have to ensure that people basically thrive, not just survive, and we have to ensure that we have to put people before profit, because I'm not sure that Labour Party are really going to do that. So I'd like Mr Hunt to explain how he's going to ensure that people are put before profit in this stage of austerity.
Okay, thank you. One more, over back there. There you can. And you've got 1 minute, Peter.
So Peter Mayer, maybe with my hat on as lead governor for the Community Healthcare Trust, these are really two questions rather than a point of view. The policy papers talk a lot about the third sector, and yet the gap that one nearly always sees on these platforms is that sector in development of policy and at the strategic end. It's seen much more as a provider part of the service. The second, John, maybe for you, is I'm on the planning group for the NHS Trusts chairs and lead governors meeting together in terms of how to work with lower levels of competition. I was very surprised when the chairs of those trusts said they had no formal access to the Health and Wellbeing Board. Absolutely. In terms of trying to develop integrated models of working.
Okay, thank you. Right, panel. Phil, you've got a question directly from the gentleman over there.
Yeah, well, I think it's right, isn't it? Because, in fact, in a sense, it comes back to the point about what do we mean by integrating health and social care. Because at the moment, the impact of disintegration can often be experienced by individuals who find you've got a load of different agencies, often with their own professional people, all kind of doing their bit, but not really combining around the person concerned. And often you find people are having to fight different agencies in order to get some support. And what we're really talking about, it's not an organisational thing. It's not saying that the NHS and social care in the city should simply be combined and run by the City Council. What it's saying is that the John and the Health and Wellbeing Board have got the core role in coordinating the activities of the current agencies, not forcing a restructuring, but ultimately having the budget and being able to influence what they do. I take the point about children's services. I think there are lots of things that we need to do and integrate between children's services and the health service, but our main aim at the moment is in relation to adult social care. On the third sector, absolutely agree, and one of the things the health service is very bad at are the kind of financial support they give to the third sector, which often is done on a yearly basis and gives a lot of uncertainty. If you think of, let's take hospices as a good example, I'd like to see much longer term arrangements so they've got stability. On TTIP, we've said that we will not sign TTIP if there is any suggestion that TTIP could be used to force the privatisation of the health service. And it was in our 10-year forward plan for the NHS, and Andy Berman has consistently made that. He's been to see the European Commissioner for Competition. He's had assurances about the European position in relation to the health service and TTIP. I'm confident a Labour government will not let TTIP used as a back way to privatising the NHS. Just finally, I know John's going to answer this question about why NHS Trust have been excluded from the Health and Wellbeing Board. All I would say is that in the future, and the way we see it, all those organisations will be round the table, because in the end, I think that's the only way you're going to get the kind of integration we want.
John.
It's always good to bring a member of the House of Lords along to answer your question for you. And good to see Peter in one of his many hats here this evening. I think that there's an issue with health and wellbeing boards as they were constituted under the current arrangements, and there's a lot of expectations and assumptions placed on them, but actually not a lot in terms of formal levers of power that we can then use to do things. So a lot of this is about the soft stuff around negotiation, relations, exhortation, if you like. We're certainly looking at how that board looks in Birmingham going forward. And funnily enough, John and I, tomorrow morning, are holding a session with members of the current board where we're looking at a number of those issues around, have we got the membership rights? Have we got the key players around the table? Are there different working methods and practices that board needs to apply? Because if you think of a health economy on the scale of Birmingham, I'll go and talk to colleagues in other local authorities and they have one CCG that neatly matches their town council boundaries, and so it's very easy. In Birmingham we've got 3 of them. One of them stretches across into Sandwell. There's a whole set of other key players from the trust world and elsewhere who have to be part of this conversation. So I think we're trying to get into a space where we define that. I think that if we get that clearer role that will be set out under a new Labour government, that will only strengthen our hand in being able to do that.
Just a very quick one from me on agreeing entirely about the need to be clearer what we mean by integration. I'm a professor of health and social care, and I'm a social worker running a health services management centre. So I'm really pleased that we're talking about partnership and collaboration and integration at a local and at a national level. At the same time, I'm a bit disappointed by the fairly sloppy way at a national level we're talking about integrated care, as if it's a sort of panacea for all our problems, without ever really being clear with each other what it actually means and what it entails. And it has been said at a national level that if you rang some policy commentators up in the middle of the night and said, "Oh, my house is on fire," they'd say, "That's terrible, John. What you need is more integrated care." Actually, we've started to say, if integration is the answer, what was the original question? Which sounds a bit facetious when you say it, but it's a way of trying to say integration is just a means to an end. Actually, let's be clearer about what we're trying to achieve together and about the kind of relationships that we need with each other, which might be very different for some children to other children, to older people, to adults with mental health problems and so on. So that integration is only ever a means to an end rather than an end in itself.
Thanks. Gerard, you wanted to say something?
Yeah, I just want to come back to the points that Robert made in relation to putting people at the centre of care. And care is determined by the people that are providing it. So it's the workers in the NHS that are the ones that are at the front line. And they're the ones that sadly have had a whole series of reorganisations that have undermined them, that have devalued their skills, has made them feel sadly in a situation where they're demoralised. And what I do think is that there are some specific steps that can be taken to not just give them back that sense of pride in the job that they do around caring for other people and the dignity that that actually entails of what they're doing on behalf of other people and on behalf of us. There are things about how many carers there are specifically. So one of the things that my union is calling for is a 4-to-1 ratio. I mean, obviously in intensive care there is a requirement for greater nursing care, but in specific areas around general nursing to patient, we believe there should be one NHS worker, one nurse to 4 patients in a hospital environment. We also think that actually the union should have a significant role in the issue around whistleblowing. For a number of people who are involved in the NHS, the trade union structure and the involvement in it, sometimes for the top-heavy management structures that are there, they're seen as almost an inconvenience and it's taking people off the job of caring, where actually trade union facility time and the ability to represent people properly gives a confidence amongst the staff that they are going to an independent organisation, as happens in many other workplaces where people will come to their union rep and tell them what's going on in the expectation, in the belief, and in many instances the right belief that we will do something about it. And I'd like to see, as part of that review, enshrined in the process that the trade unions have a fundamental role in supporting workers that are whistleblowing, and actually that then is enshrined in their activity inside the NHS. And it's not treated as an ancillary part of activity, but seen as a fundamental core activity for unions to be involved in the health service.
Okay, 3 more questions. Lady there, chap there, and bloke there.
Hello.
Lady down there first.
John Caffrey, Unite member. I noticed that CCGs will stay in place when Labour gets rid of the 2012 Act, so presumably commissioning stays in place. So does that mean contracts and tariffs stay in place, and a situation where hospitals have to compete with each other for business in order to survive?
Okay, thank you.
Hello, Joan Franklin, a social worker in children's social care in Birmingham. I'd just like to pick up on the point around children's for 2 reasons. First of all, there has been quite a bit of discussion, and I hope that politicians, obviously in this case particularly Labour Party, are going to learn from the evidence that restructuring does not bring with it positive aspects. But from the children's point of view, there is a lot to learn, I would like to suggest, from working together and also from the initiative that the Labour Party introduced for Every Child Matters. So I think there are actually 2 models from children's services and children's integration which could be used to help with the integration and to learn from how integration does work. And that has showed that it's not just a problem for children's social care but for health and police and everybody. So there is a very good model from work in children's. And secondly, I'd like to say, obviously, I do think we have to take note. Rosie's opening comments were about involvement, and obviously there are no children here and no young people, so that is an important issue to follow up.
He's quite young. Okay.
Some up the front.
There's a lady at the back there.
I'm just wondering what the position. I'm just wondering what the position will be about foundation trusts.
Mm-hmm. Thank you. And the chap there, because you've been very quick on those questions, so thank you.
Dave Halls, I work for the Star Service, part of Birmingham City Council, which is actually being cut as part of the current round of budget cuts. And I think it's great that we're having this conference today and talking about the future of health and social care and more integrated working and so on. Well, we actually do this now. We take referrals from the health service, we take referrals from social workers. In fact, one of the criticisms seemed to be when the closure's been justified is that they can't measure how much we're saving Birmingham City Council with our enablement programme because some of our referrals come from health and they haven't had a fact-banding assessment and all this kind of thing. We think it's terrible that this service is being cut, and we're hoping that the council will think again about it. I have actually been corresponding with John about this, and I've emailed you today, John. You may not have picked it up yet.
Not yet.
Okay. I'm requesting that at least you take our petitions. We've got over 1,800 people signing a petition to keep this service currently. So I'm hoping that you'll take this petition. Unfortunately, my local councillor wouldn't take the petition, and he was the person apparently who organised this conference today. So I feel, really, it's not, we should, it's actions, not just words that we need at the moment. And I understand that it's all to do with Tory cuts. I'm not in favour of what the Tories are doing at all. But we need to actually, build on what we've got and build on where
you've
people
had your
are actually
minute.
working.
Yeah, thank you.
Okay.
More than a minute. Right, okay, panel.
Yep, well,
wants to start?
Okay.
You start, Mum.
Okay, I'll start. Yeah, we will keep clinical coaching groups in place, but we want to look at their governance. And no, I don't want them to carry on with this nonsensical contracting that they're doing at the moment. I'd much rather see them working constructively across the patch, trying to get services better, trying to get rid of some of the problems we're seeing at the moment, and actually just being constructive and advising the Health and Wellbeing Board in what they do. I want to get away from this incredibly expensive and wasteful continuous contracting. It's the last thing we want to see. And in terms of the tariff, it's a very good question. What Andy Burnham's talked about is a year of care budget. In other words, where you've got a combined budget, and essentially that's what you need for health and social care. And then it's much more a question of sorting it out around the leadership of the Health and Wellbeing Board, rather than the kind of tariff we've got. Because what the tariff does, every bit of the organisation's got a different tariff. What it does is encourage them to work in different ways, with different incentives. So a hospital gets incentivised by actually pulling people into hospital, rather than trying to help people work together to get the patient experience as good as it could be. So we do want to move away from the current system of funding. I think the point about restructuring evidence is well taken. I think I took 4 bills through Parliament restructuring the NHS. I certainly learned from that you get very little out of restructuring. But what we want to do, we'll go through what we call enabling legislation. The first NHS bill, what's it basically going to say, apart from getting rid of the competition bits of the 2012 Act, is to say to every local health and care system, we will enable you to get rid of the current barriers, we'll enable you to get the money together. It's your job then to come up with a process under which you're going to do it. What we need to see is someone in charge, someone accountable for what is going to happen. So it's not going to be a top-down restructuring at all, but it will be a huge demand on local health and care systems, because, for instance, what it will mean in the future is John ultimately be responsible for 4-hour A&E waits in our hospitals as well. That's what it means. It means that he has got to sort out the whole system. It's not what we've got at the moment, where you get the ludicrous position of the hospital facing consequences for failure on 4-hour A&E, when the real problem is the whole system is breaking down. That's why we need to get to, in the end, one organisation, one person who's accountable. And John's got broad shoulders, I know, and that's what we need. We need that kind of leadership. So at the end of the day, we can say he or she, they're the people who are in charge. I'll just comment on the reopening issue. What interests me is what you said about assessments. One of the stupidest thing at the moment we have is where every different agency assesses the same person, and frankly, it's a rationing tool. It's nothing more than people actually trying to slow down giving services. And I think one of the things you could do collectively is to get rid of all this stupid multi-layered assessment, agree one assessment process to which we sign up to, and get people, what they want to get to, the service they need to get to, as effectively and as quickly as possible.
John, do you want to?
Yeah. getting a bit concerned about all this stuff being placed on my shoulders. and being called a leading member of the Labour Party earlier on. I think I should quit while I'm ahead. Thanks, Dave, for your question. Sorry I've not got back to the email yet. That's my job when I get in tonight. And I think some of the issues around STAR illustrate that point I was trying to make earlier on, around the bind that we're in terms of trying to protect preventative spending, but also meet statutory obligations around critical and substantial need. And when you've got a depleting budget in the way that I set out, some of those calls are very, very difficult to make. And I think that illustrates where we are. What I would say with regard to the mental health services aspect of this is that about 10% of the total mental health spend in this city is actually city council. So 90% of it sits with the health service. And where we're trying to get to is a conversation with the health service around how do we maximise the total impact of that spend. So we're not just doing something as a council over here and then there's a whole set of activity taking place in the health service. You know, again, very much an integration agenda. And very soon I'll be sitting down with a number of the mental health players within the city about how we try and take some of that forward. So it's part of those discussions to see, you know, how we can try and continue to sustain some preventative activity. But it does, again, I think just illustrate the challenges of the situation that we're in as a result of those spending cuts that have been placed on Birmingham, the very difficult calls that we then need to make about the interests of vulnerable people.
Gerard or John, do you want to add anything? No. Okay.
I mean, in terms of the bigger issues around the overall budgets and the impact on that, the reality is that we are faced with a situation that the economic crisis that was 2007, the impact of that bailing out of the banks is being felt right across the international community. Sadly, at that stage in 2010, there was an ability to pin that blame on the outgoing Labour government, as though there was a Labour government in Ireland, in Spain, in Germany, in France, in Italy, and in America at the same time, all faced with the same issues in relation to their budgets. And the reality is that actually you see every day in some of the things that are happening in the NHS, because of those ideological changes that have been brought in, the opportunity to save money that could go to patient care. So George Eliot Hospital in Nuneaton, that was under threat of wholesale privatisation of the whole of the hospital going along the lines of Hitchinbrook, they actually went through the process of going out to tender, and at the very last minute, because of the fact they were in the community of the NHS and worked closely with the QE here in Birmingham and managed to raise some of the standards that there were concerns about, that privatisation got pulled. But £500,000 had already been spent in the process of contracting out. £500,000 that could have gone to patient care. So there are some big global issues about what is available and the pot that we've got post May the 7th. But there are specifics like that you just know. There is still money in the organisation within the NHS that actually, if it's managed properly and the ideology is stripped out, could go straight to patient care like that.
Okay, thank you. There's one question that was asked that hasn't been answered yet. Foundation Trust, what's the future of that?
Well, it's a good question. My own view is that we've got 100 non-foundation trusts and then foundation trusts. I think we need to pull them together. I also think that the implications of the getting rid of competition, and particularly making sure we're not going to be interfered with by European competition law, is basically we have to construct the NHS as one organisation. And if we do that, then we can ring-fence ourselves out with European competition law. The implication for that is foundation trusts become much more part of the NHS than they have been. That's where I think we want to go. The one good thing about foundation trusts, I think, is their governance. I think the fact that you do have people elected to go on their governing body who hold the board to account, I definitely want to keep that. I think it's a real strength.
Okay, thank you. Well, we're not going to. I think we're going to close now. Sorry, we've had some good questions, so thank you very much for coming along. I just remind you that you've got in your pack, which you can take away and treasure. Indeed, if there's a spare one, you might take it away for a friend. A note to say what your email address is, if you want to have links, so that we can get you to be able to look at the internet and make the links to the video that there's going to be of this, and some of the materials that are also going to be made available. And we want you to also have a chance to carry on discussions as well. So there's also the chance to say if you want to join in a discussion group or a campaigning group. So please do take the opportunity to do that. And if you can leave your email address and your interest, that will help us to follow up. So thank you very much for coming. I hope you feel inspired, perhaps annoyed as well about some of the things that are happening, and go away and think about it and talk to others about what you think ought to be happening. Thank you very much for coming.
Well done, Rosi.